Good morning, everyone. Just waiting a couple minutes to see a few more folks log on, and then we'll go ahead and get started. Thank you for your patience.
Mm.
All right. Good morning, everyone. We are going to go ahead and get started. Thank you for participating in today's bias in healthcare discussion with the community education group. My name is Dr. Tamara Henry, and I am a teaching associate professor for the Milken Institute School of Public Health at George Washington University here in Washington, D.C. So now that I've introduced myself, I want to give you all the opportunity to place in the chat what type of position you hold, who you work for, just so we can know who is in our virtual room. And then we'll get started today with our bias in healthcare. So as mentioned, please let me know what your position is via typing in the chat, or you can take yourself off mute and tell me who you are. That's equally as good. Thank you. Got it. So today's learning objectives consist of explaining the difference between implicit and explicit bias, identifying at least 5 types of bias present in healthcare, describing the effects of what this unconscious bias looks like in our everyday interactions with patients, students, colleagues, and/or team members, identifying the influences of personal unconscious bias that impact one's perceptions of gender, race, ethnicity, and/or other cultural attributes in healthcare, as well as describing strategies to correct or eliminate personal unconscious biases in daily interaction. And thank you all for letting me know your various positions in healthcare, how you provide care to the populations you serve. So another question that I have for you is, when you hear the term unconscious or implicit bias, what are some of the initial thoughts that come to mind? Like when you hear it, what are the words that kind of resonate with you? If I say this individual is unconsciously biased, what does that mean to you? And does everybody have biases? Do people naturally hold unconscious bias? That could be a yes or no question. And what are the adjectives or thoughts that come to mind when you hear the term implicit or unconscious bias? You could also type it in the chat, or you can take yourself off mute. So nobody has any thoughts about implicit or unconscious bias. That's why you're here today. Okay, that works too. That works too. There are no thoughts. I received that, and I will continue to move on. So for others, when people hear the terms implicit and unconscious bias, some associate it with preconceived notions, prejudice, imbalance, something being unfair, inequality, being partially tolerant or unbalanced. The main types of balance, or rather bias, that we will be discussing today are implicit bias and explicit bias, but primarily implicit. An implicit bias is a natural occurrence that operates outside of one's person's awareness, and it can be in direct contradiction to a person's beliefs and values. So implicit bias is that initial feeling, sensation, thought that comes to mind when you interact with another individual. When you interact with another person, there are always thoughts, and sometimes it may not be what you believe, it's just a thought that you have associated with a particular demographic. Explicit bias is where the individual is outrightly clear about their feelings or attitudes towards a particular individual, and it's conducted with intent. Persons who express explicit bias are aware of their thoughts and emotions towards a specific group and typically behave in a manner that incorporates hate speech, discrimination, and prejudice. Where that implicit bias is, think about walking down the street when it's around dusk and seeing a group of teenagers on one side of the street and crossing the street. Like, not even thinking about it. You're just like, oh, I don't want to be bothered. So you cross the street. Or getting on a packed elevator with someone that appears less familiar to you, and you grab your purse or you put your wallet down at the bottom of your bag. It's that gut reaction that occurs within milliseconds. So much so that it is unconscious. You don't know why you did it, you just did it. So it's the unconscious attitude and beliefs that express as feelings, a particular behavior, or even a judgment that you are subconsciously aware of. It can directly affect healthcare outcomes and patient satisfaction, because while it's in your subconscious, the way it may present to a patient appears to be the conscious version, and the patient could have an adverse health outcome because they may not return to you depending on that interaction. Common reactions to biases include an outright rejection, where you have folks, if you say, that's a bias statement, an individual may say, I don't have a bias against X group. This isn't a real problem. Stop trying to divide us. This is offensive. So there are some people, when you try to talk to them about their bias, it's just complete and outright rejection. There are others that liken it to a polite dismissal. Some people are biased against blank, but not me. And not anyone I know. Thanks, but this doesn't apply to me. So there are folks that just think that, a session like this kind of webinar, or even enlightening them about the fact they may possess a bias, is just really misdirected. And then there's another group that has what we term as confused acceptance. I'm trying to recognize and unlearn my own biases against blank. But what should I do next? This is frustrating. So this person is kind of in limbo, can't really understand why this keeps coming up. And it may come up by way of evaluation. And they don't fully realize that the way they behave, their unconscious bias, is projecting on their client or patient interactions. So what does implicit bias resemble in healthcare? Bias in medicine means that women, people who are poor, people of color, and other marginalized populations have been historically neglected by the healthcare system, which leads to worse health outcomes. And these biases, contrary to popular belief, are not just racial and ethnic. They're bias against one's sexual identity, against a person's gender, against one's educational status, one's socioeconomic status, against one's ability. So persons who have a disability or persons who may have a mental illness, there are biases that refer to providers that don't want to work with patients who have any sort of disability. There's an ageism bias. There are on both sides, patients that don't want to have older providers, and there are providers that don't necessarily want older patients. We have copious amounts of data regarding how providers treat patients who are overweight and obese. There are providers who oftentimes, we call it blaming or shaming the victim, shaming their patients when their patients present as an individual who is overweight and or obese. And then we have racial biases, where just based on the color of one's skin, racial bias as well as religious bias, the color of one's skin or who one may worship, that there are providers that don't want to work with those kinds of populations. And then biases related to one's geographic location. So if your providers or your other clinicians know that you live in a particular zip code, there are individuals who decide that they are not interested in serving people from a particular population. These manifestations of implicit bias often occur in microaggressions. And microaggressions are terms used for brief and commonplace daily verbal or behavioral interaction that often communicate hostile, derogatory, or negative slights and insults towards any particular group, but especially those who are historically marginalized. So these manifestations of implicit bias can occur with respect to these particular statements. Nurse, can you find me a doctor? Looking at this particular Black woman and assuming that she's a nurse and not a provider, or looking at this individual who may present as if she is not a US citizen and asking this individual, do you speak English? Or similarly, looking at a person who is wearing a stethoscope, who doesn't look like what an individual may believe doctors to look like, and someone asks, are there any doctors from America here? So those are very, very common microaggressions in our public health practice, in our hospitals, in our clinics, and the like. A study from 2020 found that 83% of healthcare professionals implicitly preferred, as I mentioned, working with people who don't have disabilities. So that's a very large percentage. 83% is a lot. And In 2020, we're hearing still that healthcare providers prefer to work with people without disabilities. Can anybody think about why that would be? What do you think would be some challenges that providers would have around working with persons who have disabilities? And you can type that in the chat also. Why do you think almost 83, or actually almost 84% of providers wouldn't want to work with people who have disabilities? And you can type it in the chat, or you can unmute yourself. Thank you. Yes, thank you. Thank you both. Complexities with service delivery, yes, because that's going to take a little more time to respond to whatever challenges that person who lives with a disability may be facing, as well as if you recognize as a provider that you don't know, you don't often have patients with disabilities, so you don't know how to work with them or what the appropriate terminologies are. It could be fear of doing that, or fear of learning, learning how to address those populations. So thank you. Okay. In other news, there are other medical professionals who are more likely to view men as strong and stoic when it comes to dealing with pain. This belief can lead to men not seeking help when they're actually in pain so that they don't look quote unquote weak. Further, there's a study from 2015 that found that the majority of heterosexual healthcare professionals implicitly preferred straight people over lesbian or gay people. Additionally, a study from 2019 found that more than 80% of medical students had an implicit bias against lesbian and gay people. Now, why that's important, because we know that our medical students, let's say they're about 23, 24 years old on average, and that Generation Z group tend to be a lot more open and liberal. So I want you to think about that when we talk about implicit bias. It's not that these individuals are necessarily prejudiced, but it is that these individuals who are attending medical school have either heard from society or the institution itself that the LGBT population is X. And as a result, the way they work with these individuals has a lot of bias undertones. So it's kind of like what was stated in the earlier slide, that unconsciously, the media and society feed us a number of things that we may take in via podcast, television, news, etc., that inform our interaction or that gut feeling that we have, so that when you ask the question, do you prefer or how do you feel working with this population, folks say no. And that's a very high percentage, for 80% to say that they actually rather not work with lesbian and gay people. And that's very problematic considering the number of, the percent rather, of the population that the LGBTQ is making up. In addition, we have dark skin or darker skin being significantly underrepresented in our medical literature, in our textbooks, with just 4.5% of images consisting of darker skin. Consequently, clinicians of all licensures and specialties are insufficiently trained to recognize what disease looks like in patients of color. And this is especially problematic when we are working with folks who have chronic disease, from diabetes to heart disease to breast cancer. We don't know what scarring on darker skin looks like. We don't know if this skin keloids. We don't know what gout may look like on one body versus another. And it makes it very difficult to foster trust with patients if you don't have any patients that look like that, or when you do have patients that are diverse populations, you can't identify these diseases because you've never learned about it. Further, for more than 1/3 of healthcare quality measures, Hispanic patients receive worse care than white patients. In addition, Black, Native American, and Alaska Native receive worse care on 40% of healthcare quality measures as compared with white patients. So these biases are directly impacting the health outcomes of our underrepresented populations. So how do we begin to address these various implicit bias? Well, the first thing that I would do if I were you is copy that link. It's the implicit bias test that Harvard offers. It's a short test, but what it seeks to do is measure your implicit bias. Literally, you click on different images and associate adjectives like good or bad with darker or lighter skin or darker or lighter images. And you'd be surprised, or maybe you wouldn't be surprised, to find that the vast majority, not just of Americans, but of the world, prefers lighter skin. So if you know this, if after you take this implicit bias test, you find that you have a proclivity towards whiter or lighter skin, it would be especially important for you to be aware of that going forward. Yes, we will make sure, Jessica, that everybody gets the link to the implicit bias test, Jason, right? We'll make sure everybody gets that, because I do think that anyone who is interested in this work, this test should be given to the entire organization that you work with. And you don't have to disclose the results to anyone. It literally comes right back to you after you hit submit. And I have to say, as somebody that does this work for a living, I'm surprised by my own score. So the biases are real. Even if you don't feel that particular way, it's so important to recognize that what you have been told, how you have been educated your entire life informs how you work with other people. It informs how you work with diverse populations, even if you are the same hue as that organization. It's still very different. So I strongly suggest that everybody begin with the implicit bias test and look at your scores and look at, what it means in terms of how you interface with other human beings. In 2012, all the members of Ohio State University College of Medicine admissions committee, prior to the admission cycle, they found that the majority of their committee displayed significant levels of implicit white preference. So they too took the implicit bias test and found that their admissions committee, okay, this is the admissions for medical school, even they had a proclivity to select persons who were primarily white American. So imagine what that did to the incoming class when they noticed that admissions only preferred a particular demographic. After this test, 48% of the admissions committee became very conscious of their results when interviewing candidates, which then led to the most diverse incoming class the medical school had ever seen the following year. So many medical schools are realizing that future patients are going to suffer if the staff is not reflective of the population they serve, and also if the curricula doesn't include confronting implicit bias. So this is not happenstance. This is work. This is self-awareness. This is acknowledging that we have the proclivity to lean one way or the other and then making it right, doing the work it takes to make it right by consciously redirecting and reframing the paradigm around your biases. And as I mentioned, this should be done at an organizational level. So reframing bias is a social creation, not an individual one. So that is the reason that I am telling you it is extremely important for your institution to adopt something similar, if not the IAT, something very similar, so that everyone can know where they stand as it relates to their own biases. Our culture's biases impact us. This thinking comes from stereotypes, and stereotypes happen to be quite pervasive in our culture. They're embedded in our cultural norms, and because of that, they're normalized to us. They're normalized. These stereotypes and generalizations are just kind of what we know to be true. These stereotypes can feel like common sense. Humans can create stereotypes, and over time, they gain a life of their own and become very difficult to eliminate. Stereotypes impact our thoughts, feelings, and reactions in all kinds of situations. They affect our laws and policies so that even seemingly neutral institutions like schools and hospitals can actually function in biased ways. So they are pervasive. These biases, although they begin as innocuous, they become very damaging when we have a group, particularly at the structural and institutional level, behaving in a certain way towards a certain demographic. So what can we do? We can begin to reimagine the workplace. This can begin by way of cultural awareness training. So in order to understand and appreciate those we work with, those we serve, being culturally competent is especially helpful. And not just your one-time professional development class, but really engaging in competence where we start to have those difficult discussions and we start to unpack some of the ways that we think or the ways that we thought towards a particular demographic that we hardly interact with, or a demographic that we interact with all the time. But because we see a particular behavior from that demographic, we've decided, or we've named and or called people in a particular stereotype or generalization. So creating an inclusive work environment. Bias is not limited to what a person says or does, but it can also exist in our physical workspace. So in order to flourish, individuals need to feel like they're welcomed into a space. We also know that mentoring programs work. Companies that have formal mentorship programs see the representation of minorities increase from 9% to 24%. And more importantly, clients need to see staff who represent them. And another way to reimagine the workplace is promoting folks, promoting people who can be part of the decision-making process that are reflective of the population, can assist in reimagining the workplace. And then with every program that we implement, whether in a clinic or in a corporate setting, we need to evaluate by surveying our staff and the clients we serve to find out what is really going on in every aspect of the organization, which is why we have to assess. And when we see things that are not working, then we need to implement new policies and procedures, new practices to reframe and reimagine what was going wrong to ideally make it better. Other resolutions include focus on seeing people as individuals. So instead of generalizing groups of people, spend time considering them on a more personal and individual level. Work on consciously changing your stereotypes. If you recognize that your response to a particular person is rooted in a stereotype, make an effort to adjust your response. Why do I feel this way? Take time to pause and reflect. What we don't want to do is react to various groups in a way that is pejorative. So take some time to pause and reflect. What does that look like? Why do I feel this particular way? And recognize that what you're experiencing or what you're feeling is a stereotype towards a particular group, and then replace that stereotype with positive examples of that group. Adjust your perspective. Try seeing things from another person's point of view. How would you respond if you were in that position? So if you were the recipient of that bias, how would that make you feel? And what factors might contribute to how a person acts in a particular setting or situation? If you don't know people from other racial and ethnic backgrounds or religious backgrounds, spend time with other people and learn about their culture by attending various community events or exhibits. And then practice mindfulness via meditation or yoga or focused breathing to increase your particular mindfulness, but more importantly, to become aware of your thoughts and actions and where exactly they're coming from. So by focusing within and tuning into your own emotions, you can stick to facts without making assumptions, right? And recognize how your experience, where you were born, live, work, and play, how your experience shapes your perspective and your interaction with clients. You can learn about others and recognize how their experiences have shaped their perspectives and consider how they may see the situation and what's important to them, because their lives as well impact their behaviors. You can engage in dialogue and ask open-ended questions to folks and listen to understand. It means being an active listener and not listen to just debate that person's point. We can't debate anyone's personal experience. All you can do is listen and disentangle your impact from the intent. And instead of blaming individuals who have less than, think about them as contributors. How are they contributing to make this situation better, to make this experience and this interaction better? And then you want to expand the options. How can we provide solutions to address our implicit bias? Be flexible that there are different ways to achieve a common goal. Experiment and evaluate. That evaluation perspective is extremely important. Things may not work out the first time, but we want to keep doing it until we get it right. And then seek out diverse perspectives, perspectives that are different from your own. In summary, the first thing that we need to do is acknowledge our bias. And then we want to consider how our biases may affect our work. And then addressing our biases by consciously unlearning those patterns and replacing those patterns with positive thoughts via mindfulness, breathing, and yoga. And then putting this newfound knowledge into action. Then we have to practice what we preach. We can't learn it and keep it to ourselves. We have to learn it and then share it with others. So with that said, that concludes the presentation portion of this webinar, and I am available to answer any questions that you may have in the remaining few minutes that we have. So are there any questions regarding implicit bias and what may be currently occurring in your workplace that you would like further insight on resolving? You're welcome, Geneva. Thank you. Any questions, comments, concerns about implicit bias in the workplace or what you currently experience and or see in your workplace with respect to implicit bias? Does anybody experience implicit bias or notice, see, work with people who have challenges around implicit bias? Do you feel your organization addresses implicit bias well so that everybody is aware of their unique contributions as it relates to biases in healthcare?
I can kind of speak into it real quick. At Careful, we have like a race equity task force group, and a lot of what you talked about, I feel like, is like very similar things that we're trying to work through, like as an organization, like especially how you were talking about like the hiring aspect and like wanting people to feel welcomed or wanting new clients to feel represented, things like that, like wanting to see people that look like them. Like kind of goes in hand with like the promotion thing too as well, having people in management of all different race, gender, all, everything. We don't want it to just be one big standard thing.
Thank you, Jessica. And is that coming from the top down? Is that an initiative that has been implemented from the leadership, or is this task force just local to the department?
So it's anyone can join, which is really cool. And we actually sometimes try to not have management, and sometimes we work in smaller groups and we try to not have anyone in leadership or management, just so people can feel like they can talk a little bit more freely, and then kind of like come to leadership or management as a group, like not just saying that this one person thinks this or that, which has been kind of nice. So there are some people in leadership. I don't even think it was leadership that started it. It was just staff members, but obviously we knew that, and they knew that somebody in leadership should be represented in the group as well.
Cool, thank you. Thank you for contributing. Anyone else want to share what has occurred in terms of implicit bias work in your respective organizations?
I'm going to talk about at a personal level. So I'm a person with substance use disorder. And my experience with the healthcare system when I was in active substance use disorder versus today in sustained remission. At that, back in this would have been the mid 2000s, so like 2005, 2006. The bias so number one, almost none of the providers that I talked to who sort of discovered what was going on with me knew the term substance use disorder, and almost all of them, at least to me, appeared to have pretty strong biases against people with substance use disorder. That obviously has changed some in the intervening years, but the problem was, from an inside perspective, the problem was if as a healthcare provider someone's trying to use shame as a motivating tool to kind of like convince someone to just say no. Thank you, Nancy Reagan. The problem with that is shame is a pretty huge driver of substance use disorder in the first place. So there's already plenty of shame. And then kind of like piling on didn't help at all. And it sort of, also led to an internalizing, and then that's what that shame is, an internalizing of that bias. So kind of winding up bias against yourself almost reminds me of the doll experiments from the 1940s, kind of like in taking in that bias, believing it about yourself, so leading to like a self-hate, which then in substance use disorder just drives that.
Yeah, and it doesn't help that, clinicians, particularly back then, were not trained to address those folks. I mean, the training was to shame you to death, literally. And we see that even amongst persons who are overweight or obese. It's typically their fault. You ate too much, that's why you're like this. And, all the things that come with processing that. I see a comment from iPhone. It's difficult to know if one is making enough change since one has so many biases, how to have a priority regarding biases. Well, I think that, again, the first step is knowing that you have them. And then recognizing that if that is your initial feeling upon interaction with a particular person, place, or thing, to immediately catch it and reframe it. And when I say immediately catch it, I mean catch it before it leaves your mouth, and then reframe it. Because what happens, and people don't realize this, is that even if you hold it in the deepest part of your heart and never say anything, the people who are on the receiving end can sense it. People can sense when you are scared as a provider, when you're scared to touch them, when you are scared of whatever kind of disease they may present with. It's just something that folks can sense. So if you know that that's the kind of vibe that you're giving off, then it behooves you to say, you know what? I am actually kind of really scared to work with somebody who has HIV. Let me think about that. What am I scared of? I know that HIV can only be transmitted through 4 bodily fluids. Why am I scared to have a conversation with a person who has HIV that we're not exchanging bodily fluid? Like, what is that? And grapple with what that is before you come into contact with an individual who has HIV that you need to provide care for. So we want to be very, very conscious of why that bias exists, what you believe about people who have HIV, or what you believe about persons who are overweight, and catch that bias. We have several, as you mentioned, several biases. My response to prioritizing the bias is based on the people or the person or the thing that you're interacting with, that you interact. If you interact with patients or clients 40 hours a week, then you need to address the fact that you're interacting with people that you have a bias towards. Maybe you need somebody else to do the work until you can get it together. But you have to recognize that, because essentially you're going to drive away the clients, and the clients are not going to seek the help that they need when they know that there's a biased staff member. Does anyone else have anything they wish to contribute? We have a little more time, but again, I don't want to keep you here if you are not willing to share anything, or you don't have anything else you'd like to share. So if there are no more parting thoughts, questions, comments in the chat, you are welcome to depart. Thank you. Thanks, Jason.
Thank you.
You're welcome. Take care, Jessica. Jason, you want to hang back for a minute, and then I'll ask you about that other thing.
Sure.
Happy holidays. Thank you. And Jason, you probably can stop recording now too.
Sorry, I stopped the recording on the note taker, but I didn't realize